Hi, everyone. My name is Hannah Gallion. I'm one of the epidemiologists at the Indiana Department of Health. And I want to welcome everyone today to our summit and also introduce our first speaker of the day. So our first speaker is Eric Hawkins. He is currently the state epidemiologist at the Indiana Department of Health, as well as the director for the Infectious Disease and Epidemiology Prevention Division. Eric, thank you again for being able to speak and present today, and I will let you go ahead and share slides and take over.
All right, thank you, Hannah. Hold on one second while I get my slides up. Hannah, could you confirm that you can see my slides?
I did for a second, and then now it's a blank, your window screen. There they are.
They have now? Okay, perfect. All right. Thank you, everybody, and thanks for inviting me to speak today. As Hannah said, I'm the state epidemiologist for the Indiana Department of Health. I've been with the agency for about 7 years now, and recently was promoted to state epidemiologist late last year in 2022. And with that role, I get to continue being the director of our infectious disease epi division, where we have lots of exciting things going on. But today I was asked to do a quick update on a few different things going on in our agency, and I'm happy to answer any questions or anything that may come up, or clarification that may come up throughout the presentation or afterwards. So just to start off, we typically at Department of Health like to remind everybody what our mission and vision is, but here it is listed here on the slide. I'm not going to read it off for you, but definitely something that we take to heart and definitely strive towards each day that we work in our agency. So just to start off, I mentioned that I oversee the Infectious Disease Epidemiology Prevention Division. For some of you, that may sound like a new division, but it's not. But I wanted to just reiterate that we were formerly called the ERC, or the Epidemiology Resource Center, but we did a name change last year around the time that I was promoted. With that, I just want to make sure that our division is clear of what our roles and responsibilities are in the state of Indiana. And I think our previous title of our division was fitting during the times when that was originally put forth. But as we went through the COVID pandemic, we realized that we wanted to make sure that it was clear what our division did and what our expertise was. So that's where we came with that name change. So just a quick shout out to our team and what our new title is. And for all of you that have been around for a long time, ERC is probably much more familiar to you, but we're moving away from that name. So. Under that, I also wanted to kind of point out who our leaders in our division are, and those that kind of fall under the division as the epidemiology directors. At the top there, you'll see our vector-borne and zoonotic diseases. Dr. Jen Brown, she's our state public health veterinarian. She oversees that area where we do obviously vector and zoonotic disease surveillance, but we also do mosquito tick surveillance out in the field. We also have a field epidemiology team who Chris Tarrant actually is the director of. That team has currently around 20 staff, or at least 20 positions. Most of those are staff at this time, but they're assigned to different districts around the state, and they help support local health department response and training and those sorts of things at the local level. We have our outbreak team, who's our director, Sean Pence. She oversees that team, which includes respiratory, some of our foodborne area or enteric diseases, and sort of the flex infectious disease that kind of step in to help out with whatever may pop up, like mpox, those sorts of things. We have our, as you all hopefully you've met Trent Gully as well. He's our healthcare associated infections and AR director. He's new to the team, but he comes from Arkansas. He's got lots of experience down there in that state as well, but we welcomed him in the last few months. And then Kelly White, she's our TB director, also includes the Refugee and International Health Program, then also MBS surveillance, which hopefully a lot of you are familiar with as well. But within those teams, there are several different breakdowns within those teams, obviously, but there's close to 100 staff in that division as of as of today. So just giving you guys a quick update on COVID-19. We have come a long ways in the last couple of 2-3 years, but I wanted to give a quick update on where we're at with different things and kind of where we're at with visualization and our dashboard and some of our numbers. So as of right now, when you search the Indiana Department of Health dashboard for COVID, you'll land on this, what looks like this picture on the left side here on this slide. There are we call this our trend dashboard, and this is something we have tried to move towards for quite a while, and we're actually able to get that kind of finalized and see this is what you see now when you log in. And this is really important because it kind of reiterates the main things that we should be looking at for COVID-19, and I think moving forward, not just now, but moving forward as well. But at the top there, you'll see that top graph, that sort of lighter green is COVID-19 hospital admissions. So that's data coming from hospitals around the state, flowing into our system. And these graphs, I know they're tiny, but if you start at the very left, that's actually the beginning of the pandemic in early 2020. So you can see over time the trends of when we saw surges in cases and different things. But as you move down that slide or down that dashboard, the next one would be ED visits for COVID-like illness. So this would be our syndromic surveillance. So this is individuals that are going to a ED and actually presenting with COVID-like illness or COVID-like symptoms. And we monitor that through several different EDs around the state. As you can see, it matches hospitalizations, hospital admissions, those sorts of things, and also some of the other metrics as well. But this is something we don't have to count or bring in through electronic lab reporting. This is just a syndromic piece that we analyze data that's coming through EDs throughout the state. The next one is the red graph there is the COVID-19 deaths. As you can also see, that trend line tends to go with the rest of the graph trends there. But you'll see as you get farther to the right, you'll actually see the deaths, the numbers actually going down in comparison to the number of cases and number of activity that's happening. So that's a good thing in our eyes, but we want to make sure I wanted to make sure to point that out, that we're still monitoring COVID-19 deaths, and we used to routinely get COVID-19 deaths on a regular basis, daily basis, but thankfully not as severe as we were in the past. The yellow line, which I think will change over time, but we'll still continue to look at those numbers, is the COVID-19 cases. As you know, people I think are much less likely to get tested today than they were a year ago, even, or 2 years ago for sure. And the bringing on of at-home tests really changed that landscape as well. As we know that we're not actually capturing those at-home tests, they're not reportable to us. We're not making them reportable to us. So that's why we wanted to focus a lot of our efforts on other types of surveillance as well. As you can see, the case numbers don't tend not to go up as drastically as we see some of our other key metrics like hospitalizations and syndromic data and deaths. So, and that last line is something that we hope to maintain for not just COVID, but some other diseases in the future, is our wastewater surveillance. So as you can see, that's also a really good indicator of what's happening within the community as far as wastewater surveillance for SARS-CoV-2. And I have a slide a little bit later to show that some more. So that, sorry, I wanted to go back one more. So that's just that's our landing page, and hopefully that's a dashboard that others can use and at the hospital level can use and find useful as a useful tool, and something we will continue to use in the future. We do have some additional tabs within our dashboard that you can go through, and these are some of the ones that have been around for a while as well. So this is our page on hospital resources. So this would be hospital, I'm sorry about that. So we have the first picture on the left is actually our hospital census. So that's the number of individuals in the hospital. And then the one on the right would be the number of admissions over time. So as we like to see, those trends are down, but just want to make sure that you guys realize that this is still a resource on our dashboard. And as I mentioned, wastewater surveillance has become something nationally that everybody's looking at quite a bit. This is our newest, one of our newest dashboards. This is our wastewater surveillance dashboard specifically for SARS-CoV-2. As you can see, there's a map there, and we can look at where all the wastewater treatment plants around the state that we're actually getting samples from and testing either at our state laboratory or through a third-party lab, BioBot. But it's a good indicator of what's happening within a community. It doesn't require anybody to go get tested. This is just literally taking samples from wastewater, looking at concentration levels, and then extrapolating that into a usable data source. So currently in our state, we have 24 wastewater sites around the state. As you can see pictured there, we try to do a good job of getting those onboarded, so we have a good representation around the state. With all that, we look at what's called the catchment area. So which population within a region or within an area actually where does their wastewater flow? So that catchment area, that sewer shed. When we look at that sewer shed across the state, we're capturing about 1.9 million people across the state. So it's a good representation of the state as a whole. But as you can see, the wastewater has tended to go up and down based on cases within the community. If we do some analysis and we had this pretty real time, we'd be able to see that wastewater concentration levels actually start increasing about 1 to 2 weeks before hospitalizations for COVID actually start to increase. We have to take into consideration over time too the severity of illness with different COVID strains and vaccination efforts and better treatment options. So hospitalizations don't necessarily correlate, but it does give us an early lead time to look at where we're at with some potentially severe illness in the future with COVID-19. In the future, we hope to look at other things. There are laboratories around the country that are doing additional searches or doing additional testing on wastewater to look at different viruses, even some bacteria. So there's additional things coming from CDC in the future where we can look at adding additional things. We could look at things like influenza, even norovirus. RSV is another thing that's been on some of the panels. We actually have on CDC's website, Indiana actually has Mpox detection within the state. Thankfully, we're not seeing any increases there, but just different things that we can look for in wastewater without actually capturing a human specimen from a laboratory. And then just quick update from CDC's perspective on COVID-19. We do have Indiana's all green. This is a recent picture, so that map is good. We're not seeing large increases in COVID-19 right now. Our deaths are fairly low compared to where they were in the past, and our hospitalization admissions are low as well. I do want to mention there's a lot to learn here, and if there's questions on this, I'm happy to kind of take those. Definitely not my area of expertise as things are continuing to change here. I know with there's still in effect a federal COVID-19 public health emergency that is due to expire in the next couple of weeks, actually. So there will be some changes to some of that. So if there's additional questions around this, I know Dr. Weaver has shared a lot of this on some of our provider calls in the past, and we'll continue as we get closer to that end date there. But just highlighting a few things here. So that second bullet there, the PrEP Act immunity from liability will be extended through December 2024. That includes pharmacists, pharmacy interns, technicians that are able to administer COVID-19 and seasonal flu vaccines. And then COVID-19 tests, regardless of any U.S. government agreement or emergency declaration. So all those pieces will still be extended through the end of this year, or through the end of 2024, I should say. Next, extending coverage through 2024 for federal agreements. This also includes all activities related to the provisions of COVID-19 countermeasures. So number one, provided based on federal agreements. So that includes vaccine and treatments purchased and provided by the U.S. government, or two, directly conducted by the U.S. government, including federal employees, contractors, or volunteers. And then also the fourth bullet point there, ending of coverage for certain activities, COVID-19 vaccination by non-traditional providers, so recently retired providers and students, and COVID-19 vaccinations across state lines by licensed providers and pharmacists and pharmacy interns. So I know that was relied on a lot when we were trying to get a lot of vaccine out, but some of that coverage will be ending at the end of the public health emergency. And then that last bullet there, ending of coverage for routine childhood vaccines. So once there's no emergency in effect, the PrEP Act coverage no longer extends to all routine childhood vaccines by pharmacists, pharmacy interns, and pharmacy technicians. Just to highlight a few key features that will not be changing at the end of the public health emergency. So as noted in the previous slide, the amended PrEP Act declaration will not have any immediate impact on COVID-19 vaccines, treatments, and tests that are currently distributed by the U.S. government, either now or when the public health emergency ends on May 11th. There also will be no change to coverage for certain prescribing and dispensing of COVID-19 oral antivirals. And then the last one there, there's no change to the test to treat programs. So essentially pharmacists and other providers that are prescribing tests for the test to treat program will continue to receive liability protection under the PrEP Act as well. All right, so I wanted to also touch base on the just influenza in general, where we're at with our 2022-2023 influenza season. As you can see here, hopefully you guys have seen this and it's useful. We had switched last year to more of an interactive dashboard rather than just our static PDF influenza weekly report. So this dashboard that's on our website, and you can see the link at the bottom of that slide there. This is a dashboard that has interactive tabs, and it really gives us all the information that historically was in our weekly PDF influenza reports, but it makes it a little bit more visual. You can also, as you get into some of the other tabs on the top, you can also transition between different years or different seasons, I should say. But happy to share that we continue to see our ILI activity, so influenza-like activity. So that's our, again, syndromic surveillance within hospitals or EDs. That's very minimal at this time. We're not seeing our influenza-associated deaths have decreased quite a bit. We have seen quite a few deaths throughout this season so far, 261 so far this season, but which is considered one of our higher years for influenza deaths. But I will say that we've done a lot better job of coming through and improving our surveillance systems, but just due to COVID, we've been able to improve all those metrics, been able to providers work with our systems efficiently, effectively. So I think we've seen a lot of improvements in surveillance in general. As you can see from the slide, we're seeing syndromic, the number of people going to an ED right now, just over 1% of those individuals are actually experiencing any sort of influenza-like illness symptoms. If you scroll through our dashboard, this is just a highlight of our current season and ILI against that, so that syndromic piece. You can see that maybe hard to see that, but that first peak you see, it's more of a brownish color line. That's our current season. As you can see, and everybody was talking about, especially early on, was that we were seeing high influenza activity super early this season, much higher than we've seen any time in the last 5 or so years. So it peaked super early. It was high, one of the highest activity seasons we've seen in a while. But it peaked really early, which was also unusual, and then it kind of trickled off. And thankfully, we haven't seen a typical surge that we usually see in the second part of the flu season. That number has stayed low down there. And then, as I mentioned, influenza deaths we've seen quite a few, unfortunately seen quite a few influenza deaths this year. You can see that also peaked early, which makes sense based on when we were seeing our influenza activity. But thankfully, again, those numbers have trailed off throughout the season. Looking at the national level, nationally, just like Indiana, we're seeing activity remains low. 9 out of 10 regions across the country are below those respective baselines. Flu hospitalizations, thankfully, again, remain low. If we're looking at the latest week that has data at the national level, we're seeing that over half of the influenza types that are samples are being typed as influenza B. So that's not unusual at this time of the year. We transition to more of the influenza B. Influenza A is still making up about 45% of cases right now, based on some of the surveillance data, and most of those are H1N1. Current estimates at the federal level are saying that currently in the season throughout the U.S., we've seen 290,000 hospitalizations due to influenza and 19,000 influenza-associated deaths. The good news is that we didn't see a lot of shifting this year in the virus, so the seasonal influenza vaccine still remains effective and is a good match. So it'll be good to see some of that data when it comes out about the vaccine efficacy this season, but it looks like everything has been very effective, and hopefully why we saw a lot of the changes in our influenza activity and severe illness. Another cool thing that came out this year from the CDC, and we hope to do something very similar in Indiana once we were able to make some of these connections. As many of you probably know, RSV is one of those respiratory conditions that was also had a lot of high activity this respiratory season, and at a different time than we usually see it too. But RSV is not reportable in Indiana as a laboratory result, so it's hard for us to get any surveillance data. But there are enough sites around the country that we can get some of this data to extrapolate. But what this graph shows is just combining, like it breaks down by different respiratory pathogens that we saw throughout the country. If you look at the combined line, the black line, you can see that there was around the time everybody was seeing Indiana was seeing high influenza rates. Everybody was nationally as well. But RSV was up, influenza was up, COVID-19 was also kind of surging around that time as well. So just that the triple viruses that were influencing a lot of illness throughout the country were really peaking around late November, early December there. But thankfully, all those have trailed off even nationally, not just Indiana. This is just another slide from the CDC. Again, this is that respiratory dashboard that they've developed, which is a really good tool, and hopefully you can use it at the local level as well, just to see what's going on nationally. But this breaks it down by different age groups, and you can see every age was affected throughout the season, the respiratory season. I also wanted to touch base on we sent out an IHAN last week, and we trying to look at some different ways to get messaging out to the community, providers, local health departments, and public health in general. So last week we had several updates that we wanted to get out. So we actually combined 3 different key topic areas, but I wanted to cover those briefly here on this call to make sure that everybody has the information, and if anybody has questions, I'm available to answer some of those. But first, I just want to put a quick plug into our Indiana Health Alert Network system. So if you're not part of this, I would recommend you do that. We do send out some important messages through this system. But just right here on this slide, there's actually a link on there that'll take you to our IHAN network. Anybody can sign up for this. But it is a massive notification system that's intended to distribute health alerts to healthcare providers and public health across the state. But as I mentioned, anybody can get the access to this. So we do tailor the message to providers and public health professionals in general, but super simple to sign up. Go to that link, and on the right side, you'll see a box on the right that shows you how to register and get registered through that. And if you have questions, feel free to reach out with that as well. But just highly recommend people get sign up for that to get the important messages that we do send out. So last week, as I mentioned, we sent out a few different updates. The first one was about COVID-19 vaccine updates. And if you have been paying attention to some of the things coming through FDA and CDC, there was some updated information that hopefully has simplified the COVID-19 vaccine recommendations, and that also followed up with sort of the FDA that they gave out some information the previous week as well. So these are based on a lot of the CDC recommendations that came out here, these updates. So right now, so the changes that were included in these updates allow for an additional updated bivalent vaccine dose for adults age 65 years and older, as well as an additional dose for people who are immunocompromised. So this should allow for more flexibility for healthcare providers to administer additional doses to immunocompromised patients as needed. The update also that was brought up also shows that the monovalent, so that original vaccine that was available, the mRNA COVID-19 vaccine, that one is no longer recommended for use in the United States and is actually no longer authorized by the FDA. CDC recommends that everyone ages 6 years and older receive an updated bivalent vaccine, regardless of whether they previously completed their monovalent primary series. And then also individuals age 6 and older who have already received an updated mRNA vaccine, they do not need to take any additional action unless they are 65 years or older or immunocompromised. For young children, multiple doses continue to be recommended, and they do vary by age and the type of vaccine. Alternatives to the mRNA vaccines that include some of the monovalent Novavax or J&J or Janssen COVID-19 vaccines were not affected by these changes, but CDC now recommends the use of bivalent vaccine for all recommended mRNA COVID-19 vaccine doses. With that, they also wanted to give information about what we should do to minimize administration errors around vaccines now that we have these new changes. So it is recommended that we remove all monovalent our mRNA vaccines from storage units, even if they're not expired. So that includes some of the other vaccines that had an EUA. And then actually dispose of all monovalent mRNA vaccines vials in accordance with local, state, and federal regulations. And then report all disposed inventory as wastage. So CDC and ACIP will be updating their product-specific doses and intervals of administration in the interim clinical guidance, as well as continue monitoring COVID-19 disease levels and vaccine effectiveness in the months ahead, so we can continue to monitor those vaccines. The other update that we gave in our IHAN was around invasive group A streptococcus, or IGAS for short, infections. We have pushed out a message late last year that came through from the CDC, but the CDC in general had noted an increase in invasive group A strep in several areas around the country towards late 2022. And that's continued actually even currently in 2023, even as we're getting into several months into 2023. Indiana as well has experienced that increase beginning in November of 22, and we're continuing to monitor that here locally as well. So just looking at some of the preliminary data in Indiana, we averaged just over 83 confirmed cases per month between November and March 2023. Compared with that average, if we look back a few years, going all the way back to 2017, we would average just under 24 cases per month. So quite a big increase on that. And that has been observed statewide and has occurred among both children and adults. So this isn't just one specific group. As I mentioned, CDC pushed out an IHAN in December of 2022. Just looking at the increase in pediatric and group A strep infection, or sorry, invasive group A strep. And then we also want to look at our pediatric population around that time as well. So just looking at those under 18 in the state of Indiana, we were seeing about 42 cases between November 22 and March of 23. And then if we look at that annually, looking back a few years, we usually average around 14. So again, we're seeing big increases in that pediatric population. If we go even back 5 years before the pandemic, so like 2015 to 2019, we would average around 21 annually per year. So not just within per month, but annually. So definitely some big increases there. And then the CDC HAN also had additional information about for providers about what to look for and any additional information needed there. I also want to touch on Marburg virus. We gave an update in that IHAN as well. And just as a reminder, Marburg virus it's a rare disease, but it's highly fatal, just like Ebola. But it's caused by a couple of different zoonotic viruses, Marburg virus and Raven virus, which again, I mentioned they're very closely related to the Ebola viruses. So February, March of this year, there has been 2 outbreaks of this virus in Africa. And the first one was started off in Equatorial Guinea, and then soon after there was also an outbreak in Tanzania. These countries are not next to each other if you look at the geographical map. So there's no epi links between these 2 countries. So there's assumed spillover events happening from animals within those within those environments. So they're not spreading between those 2 countries. The risk is low right now, and that's the message that we continue to push out, and also CDC. But in saying all that, there is CDC is asking travelers from that area to self-monitor for symptoms and contact their local health departments or their clinicians if they get any symptoms that are compatible with Marburg virus. To date, there has been no cases related to this outbreak that have been reported either in the United States or even outside of other countries, outside of Equatorial Guinea or Tanzania. CDC, I mentioned that CDC is asking travelers to monitor for symptoms when they do leave those countries. So they're sending text messages to those individuals about what they should look out for and who they should contact if they develop symptoms. The other reason this is also low risk, these are also countries that there's not a lot of flights to the United States in general, but also not a lot of direct flights or commercial flights from those two countries into the United States. So again, on the ground, CDC is helping those two countries with testing and surveillance and contact tracing, but also is monitoring any individuals that are leaving if they're at high risk. So again, low risk, but something we just want to make sure that the providers, public health, and also providers in the community are aware of. And then the last thing I want to touch base on is just communicable disease rule updates. So hopefully you've seen some of this information that was passed out earlier this year. But I did want to kind of touch base on where this came from and kind of where we're at and what we're doing moving forward on the communicable disease conditions. So we had our last major update to the communicable disease rule back in 2015. As you can imagine, there was it's not an easy process to get a rule updated. But at the same time, we also we were working on some things as well before we hit COVID. So, but in 2019, so not too long before COVID started, there was a Senate bill that we helped put together with our agency leadership and legal team. That was called Senate Bill 228 or 228 that amended our Indiana Code Title 16, which is our health code. And what that amendment really did was helped us to, the State Department of Health allows us to actually publish our rules, or sorry, our reportable communicable disease conditions outside of the rule. So historically, everything that was reportable in the state was actually listed within rules. So every time we wanted to change or update that, we actually had to go through a whole process to do a rule change with our legislation. So this amendment allows us to pull those out. So really allows us to put that list on our website, and then it allows us to then change as science changes or as new conditions come up. We can add things to that communicable disease list to help protect help protect Hoosiers and give guidance for providers within the community. And also allows us to update our control measures. So as those things change, as science changes, we can update those as well. So this was, in general, a very good thing for us and pretty progressive as far as reportable conditions go. Not too many states have something as flexible as this. But as you'll see, we'll move through sort of how we update these things in the future. So the advantage this gives us is a really, like I said, allows us to keep up with science, but also streamlines a lot of things for us. So some of the information that we changed earlier this year was around streamlining timeframes for reporting. So we had a lot of things. We had some conditions that were reportable within 3 business days. We've updated those. So now we have just 2 different classifications. So things that are immediately reportable upon suspicion, or things that are reportable within 1 working day. So those things aren't quite as immediate, or things that we don't have to take public health action immediately. We also updated all the reportable disease lists for hospital providers, as well as the list for laboratories. If you're not familiar, we do have 2 requirements. So the hospital providers are required to report, and also laboratories are required to report once they identify something that's reportable. And we made these changes effective April 1st of last year, or sorry, this year. So as I mentioned, there's 2 different lists there. This is kind of gives you a highlight of what those are and the 2 different audiences there. But we do care about both of those here at the State Health Department in our division. And this is the updated spreadsheet or I guess the reportable condition list for healthcare providers and hospitals. As you can see, we've updated that guidance, not the guidance, but the actual format of those to make it hopefully more easily usable. And there's information on there how to report conditions as well. And then this is the updated list for laboratories. I know there's a lot on there, but I'll cover some of the highlights here in a second. So things that we moved to immediately reportable and or added to the newly immediately reportable list are novel influenza A. So I think historically we had it reportable within 24 hours. So we've changed that so it's immediately reportable. and then MERS, melioidosis, SARS, and other viral hemorrhagic fevers. So things on this list are things we're not going to see frequently, thankfully, but things that we want to make sure were added to that list. So the actual number, total number of immediately reportable diseases has actually increased because we did take some things off of there as well. We did update things to 1 working day, as I mentioned. So things that were previously 72 hours or 5 business days are now reportable within 1 working day. And I think that helps with just reporting in general, but also as I think when these rules were originally created, it made sense to give more time because a lot of things were paper-based and faxed into the state health department. But now as we move towards electronic things, I think it makes sense to continue updating that guidance as the technology and science changes on some of these conditions and reporting structures. The changes also include some diseases that were previously immediately reportable. So on the right there, you'll see the summary of changes. We added some diseases. We took some things, changed some of the scope on some of those things. We regrouped some things to make them a little bit easier to read and visualize on our documents. And then we also took some diseases off the list that are no longer reportable. So again, this simplifies sort of the disease pathogen reporting timeframes for healthcare providers. There's not as many things to keep track of. Allows IDOH to easily change and update reportable diseases as needed, and then increases reporting guidance. We did increase the reporting guidance for healthcare providers and laboratories through some of the guidance documents that we put on our website. And then no impact to reporting methods. So if you're used to reporting NBS, you still report in NBS. We also have our communicable disease report, or the confidential report of communicable diseases. That has not changed, just been updated in format. Just a quick slide here if you need information on how to report. So those are the different ways to report, and we prefer NBS. So if you're not an NBS user and feel like you should be, you can gain access to that. But there's also other ways to report as well. And then I also want to touch base on just the future of these changes. So we did this amendment to our rule to allow us to make things more streamlined and effective for updating in general. But we also don't want to be updating things throughout the year and as things pop up. However, there might be emergencies that pop up, like COVID-19 was a great example where we were able to, as a state, add it to our reportable condition list because of the way that our rule is set up. So we're easily able to add that. But what we're asking my team here and others within our agency to do is throughout the year, they should be looking at what's reportable in their area under their subject matter area, making sure that everything is up to date, making sure that it still matches what's happening at the CDC. Also makes sense within our community providers. So definitely getting input throughout the year on from our community experts, providers, public health experts in the field. But also getting updates from CDC and also the CSTE, so the Council for State and Territorial Epidemiologists. So that should be happening throughout the year right now. But then as we move towards closer to the end of the year, if there are things that we want to make sure that are changed or updated within our rule for reporting, we'll start working on those drafts late in the year, around September through October. Once we have those drafts, we'll be working with providers and community experts as well on those drafts. And then any new changes that we want to make to the list, we'll be making announcements through like IHAN system and other communication through laboratory channels, those sorts of things. We'll get those pushed out by December 1st each year. If there's no changes, we may announce that too, but if there's no changes, there wouldn't necessarily be anything to change at the local level. And then any new changes will go into effect on January 1st in the future. And that's actually the last of my slides. I'm happy to answer any questions if there are any. I guess I'm not able to see the chat, but if there's any questions or anything like that, I'd love to answer those.
Please enter any questions you have into chat or the Q&A function, and we will make sure that those are addressed. One question that did pop up is there a distribution list that you can join to be notified of changes to the rule or any new reporting?
So in the future, as I mentioned, I want to make sure that we're I want to make sure I stop sharing there. There we go. So in the future, we plan to push out messaging towards the end of the year, and that we IHAN is a great system for us to do that, so we plan to do that. But also, I know in the last rule changes, we tried to work with different organizations throughout the state to get those messages out through our different partners. So if you have ideas of additional partners or messages that need to go out, we can do that. But we tend to push them out through our normal channels.
Thank you.
Eric, can you also mention if anyone has questions about the new communicable disease rule, who the best point of contact would be for those?
Yeah, so I think that depends a little bit, Hannah. I think we have our surveillance team here that really help put together some of these, so they can help with that. So that's Kelly White's team. But I really encourage you to reach out to your subject matter experts here at the Department of Health, or myself, if you have questions or ideas about or things that are we considering in the future. We're happy to take that input now throughout the year and get that. So anybody within the division can help you with like actual specific organisms, but in general, Kelly White's team is the one that's helping me to continue to update that rule and that communicable disease list.
Thanks. And then another question that I thought of during your presentation, a couple of times I think you mentioned provider calls. If facilities are not currently on those calls or feel that they should be, who should they contact to get on those lists?
That's a good question. Let me honestly, since you guys have my email address, feel free to reach out to me. And I'll work with Dr. Weber and Dr. Bupalanchi and our end to figure out how to get who's on those distribution lists of it and stuff like that. So please feel free to reach out to myself if you want to be added to those provider calls. Well, thank you, everybody. And like I said, my contact information was on the slides. Feel free to reach out to me with any additional questions that you have, but glad I was able to partake in the present or share some information with you guys today, and I'll stick on for a little while as well.
Thank you so much. We really appreciate it, Eric. So at this time,